Hello everyone, a very warm welcome to Global Associations for Physiotherapy. This webinar is sponsored by Maharashtra State Team. Our Maharashtra State Team President is Dr. Pranoti, Dr. Dimple, she is a Vice President, Dr. Prerna Gadge, she is a Treasurer, Dr. Priyanka Patole, she is a General Secretary, Dr. Mugdha Shribas, she is a Joint Secretary, and Dr. Manisha, she is the executive member. So today's speaker is Dr. Prerna Gadge. Let me give her short introduction, what she is and what she is doing. Dr. Prerna Gadge, she is a consultant physiotherapist at CSIR and NERI, Nagpur, that is Council of Scientific and Industrial Research, National Environmental Energy Research Institute. Since from last 10 years, she is working as a consultant physiotherapist at Sunrise Multispeciality Hospital. I would like to request Dr. Prerna Gadge to start with the sessions. Before that, I would like to request all the members kindly keep their mic and videos off so that the webinar can run very smoothly. And whatever queries, if you have, you can text or you can ask at the end of the sessions. So it's a request to Dr. Prerna. Could you please continue with the session?
Yes, thank you so much. Welcome to this ankle joint anatomy webinar. You can see my slide, ma'am?
Yeah, it is visible and you're audible also, madam.
Okay, thank you, ma'am. Let's begin with the ankle joint anatomy. I will begin with the anatomy surfaces. We will see for the surface anatomy of the ankle joint. Here we see the dorsal surface, the plantar surface. This is the dorsal surface you can see here of the ankle and the foot, and this is the plantar surface of the foot. This is the bony prominences you see here is the medial malleolus of the tibia. This is the medial surface or the medial side of the foot, and this is the lateral malleolus of the fibula, and this is the lateral side of the foot. Next, we will come to the bones forming the ankle and the foot. The bones divided into the tarsals, metatarsals, and the phalanges. Tarsals, we have 7 tarsals, metatarsals are 5, and phalanges are 14. The tarsals are divided into the distal and the proximal. The proximal tarsals are formed by the thallus, the calcaneum, and the navicular. The distal tarsals are formed by the 3 cuneiform, this on the medial side, and by the cuboid on the lateral side. The metatarsals are 5 in number, you can see here, and the phalanges are 14. The great toe has the distal phalanx, and this is the proximal phalanx, and the second to the fifth toes are divided into the middle, the distal, middle, and the proximal phalanx. Now the parts of the foot is divided into 3 parts: the hind foot, the mid foot, and the forefoot. The hind foot, it is the bones forming the hind foot are the talus and the calcaneum. Midfoot is formed by the cuboid, the naviculus, and the cuneiform, and the forefoot is formed by the metatarsals and the phalanx. Now we will come to we will cover this anatomy in the form of ankle joint, the subtalar joint, and the foot. The ankle joint will be covered under the subheading as the bones, the type of the joint, the articular surfaces, the stability, ligament, muscles, movement, blood supply, and nerve supply. Coming to the bones, the ankle joint is formed by the 3 bones. The tibia, this is, you can see the tibia. This is the fibula on the lateral side, and this is the talus. The tibia has the medial malleolus. This is the tibia. This is the lateral malleolus of the fibula, and this is the talus. The talus fits inside the socket formed by the lower end of the tibia along with the medial malleolus and the fibula along with the lateral malleolus. They form a socket where the talus fits. The ankle joint worked on the concept of the mortise and tenon as applied in any wood furniture making. Here, the distal tibia. This is the distal tibia, and this is the distal fibula. And along with the two malleoli, they work like a mortise. That is a hole. You can see here the distal fibula and the distal tibia work as a mortise, and the talus works like a tenon to fit inside the mortise. Type of joint, it is a hinge. The talus works like a hinge to allow the dorsiflexion and the plantar flexion movement. It is a synovial joint, and it is also called the talocrural joint. Next is the distal tibiofibular joint. This is also called the ankle syndesmosis. In the ankle joint, there is distal tibiofibular joint. It tightly binds the tibia to the fibula. It is classified as syndesmosis. This gives stability to the ankle joint. The articular surfaces are formed by the concave tibia. This is the concave tibia to the convex planar fibula. This forms the ankle syndesmosis or the distal tibiofibular joint. They allows some sliding or rotational movement between the two bones. This plays a major role in the stability of the ankle joint. Now coming to the articular surfaces. The articular surface is formed by the superior articular surface and the inferior articular surface. The superior articular surface, you can see the red color line, and the inferior articular surface, it is the blue color line. The picture shows the posterior. The picture shows the posterior view of the frontal section of the ankle joint of the right leg. The superior articular surface is formed by the lower end of the tibia. The lower end of the tibia, including the medial malleolus, the lateral malleolus of the fibula, and the inferior, the transverse tibiofibular ligament. You can see the next picture. The inferior articular surface is formed by the articular areas on the upper, the medial, and the lateral aspect of the talus. The depth of the superior articular surface is contributed by the downward projection of the medial and the lateral malleolus. The inferior transverse tibiofibular ligament that bridges the gap between the tibia and the fibula behind the talus. Coming to the ligaments give stability to the ankle joint. The joint is supported by the fibrous capsule, the deltoid for the medial ligament, the lateral ligament, and the ankle syndesmosis. Coming to the fibrous capsule, the fibrous capsule is attached all over the joint, all over the articular margins, with two exceptions: the posterior superiorly and antero inferiorly. This is the posterior view and this is the anterior view. On the posterior superiorly, it is attached to the inferior transverse tibiofibular ligament, and anterior inferiorly, it is attached to the dorsum of the neck of the talus. The anterior and the posterior part of the capsule are loose and thin to allow the hinge movement. On each side, however, it is supported by the strong collateral ligament. Next is the deltoid or the medial ligament. This is very strong triangular ligament present on the medial side of the ankle. The ligament is divided into the superficial and the deep part. The superficial part is divided into the anterior fibers or the talonavicular. You can see in the yellow line, this is the anterior fibers, the anterior tibionavicular part, the middle fiber, the tibiocalcaneal part, and the posterior fibers, the posterior tibiotalar part. The anterior fibers or the tibionavicular part, first this one, it is attached to the tuberosity of the navicular. This is the navicular bone. It is attached to the tuberosity of the navicular bone and to the medial margin of the spring ligament. This is the spring ligament. The middle fibers or the tibiocalcaneal are attached to the whole end of the substanticular tala, and the posterior fibers or the posterior tibiotalar are attached to the medial tubercle of the posterior process of the talus. The deep part, coming to the deep part, it is the anterior tibiotalar. It is attached, the blue line shows the anterior tibiotalar part. This is the deep part of the medial or the deltoid ligament. It is attached to the anterior part of the medial surface of the talus. The deltoid ligament is crossed by the tendons of the tibialis posterior and the flexor digitorum longus. Now coming to the lateral ligament. The lateral ligament consists of three bands as follows: the anterior tibiofibular ligament, this one, the posterior tibiofibular ligament, and the calcaneofibular ligament. The anterior talofibular ligament is black band which passes from the anterior margin of the lateral malleolus to the neck of the talus. The posterior talofibular ligament passes from the lower part of the malleolar fossa of the fibula to the lateral tubercle of the talus. The calcaneofibular ligament is a long rounded cord which passes from the notch on the lower border of the lateral malleolus to the tubercle on the calcaneum. It is crossed by the tendon of peroneus longus and brevis. Morphologically, the medial ligament is more stronger than the lateral ligament. Coming to the angle syndesmosis ligament. We have seen the distal tibiofibular joint in the previous slide. Here we will see the ligament that supports the ankle syndesmosis. It is formed by the anterior inferior tibiofibular ligament, the posterior inferior tibiofibular ligament, and the interosseous ligament. The anterior inferior tibiofibular ligament connects the tibia and the fibula in front of the ankle. The posterior inferior tibiofibular ligament, you can see in this picture, connects the tibia to the fibula behind the ankle joint, and it is the transverse ligament. This is the interosseous ligament. It lies between the tibia and the fibula It is a long sheet of connective tissue that connects the entire length of the tibia to the fibula from knee to the ankle. Now coming to the movement at the ankle joint, we have two movements that occurs at the ankle joint. One is as the ankle joint is the hinge type of joint. Two movements occur here. First is the dorsiflexion. In this, the forefoot is lifted up, as you can see. The ankle between the front of the leg and the dorsum of the foot is decreased. It is a closed back position of the ankle joint with maximum congruency of the articular surface and tension of the ligament. The ankle, it is more stable in dorsiflexion and it is restrained by L4, L5 spinal segment. The range of motion of dorsiflexion is 20 degrees. Next, we have the plantar flexion. Plantar flexion, the forefoot is depressed. The ankle between the leg and the foot is increased. It is a loose back position of the ankle joint. The joint is unstable in plantar flexion. The range of motion of plantar flexion is 50 to 60 degrees and it is restrained by S1, S2 spinal segment. Next, we have the muscle producing the plantar flexion and the dorsiflexion. The main principal muscle of dorsiflexion is the tibialis anterior. Here you can see the accessory muscles are the extensor digitorum longus, the extensor hallucis longus, and the peroneus tertius. Plantar flexion, the principal muscle is the gastrocnemius and the soleus. The soleus lies deep to the gastrocnemius. The accessory muscles are the plantaris, the tibialis posterior, flexor hallucis longus, and flexor digitorum longus. Now coming to the relations of ankle joint, anteriorly from medial to lateral, we have in the next picture we have the tibialis anterior. You can see the two lines. Then we have the tendon of extensor hallucis longus, which is shown by the green line. Then we have the extensor digitorum longus, which is shown by the blue line, and the peroneus tertius, which is shown by the orange line. And also we have the anterior tibial artery. These all the relations are from the medial to the lateral of the anterior compartment of the leg. Now the relations on the posterior-medial side, from medial to lateral, we have the flexor hallucis longus, which is shown by the green color line, and we have the flexor digitorum longus by the orange color line, all before, and the tibialis posterior, which is shown by the yellow line. And on the posterior lateral side, we have the peroneus longus and peroneus brevis, which is shown by the yellow line. Now coming to the blood supply. Blood supply by the dorsalis pedis artery and the posterior tibial artery. The dorsalis pedis artery, it is the continuation of the anterior tibial artery. It runs in front of the foot. It runs in the front of or the dorsum of the ankle to the top of the foot, and then inferiorly as a deep plantar artery between I'll begin it again. The dorsalis pedis artery, it is the continuation of the anterior tibial artery. It runs in front of the dorsum of the foot, and then inferiorly as the deep plantar arteries between the metatarsals and metatarsal 1 and 2 to enter the sole of the foot. You can feel the pulse of this artery in the middle and the top of the foot. Next is the posterior tibial artery. It branches from the popliteal artery via the runs behind the medial malleolus. It sends small blood vessels to the inside edge of the ankle joint, that is the plantar surface of the foot. The posterior tibial artery enters the sole and bifurcates into the medial and the lateral plantar arteries. You can feel the pulse of this artery behind the medial malleolus. Now coming to the nerve supply. Nerve supply by the peroneal nerve and the posterior tibial nerve. The posterior tibial nerve, it is the branch of the sciatic nerve. It runs behind the medial malleolus and enters the foot to the proximal tarsal tunnel, where it divides into the terminal branches, the medial and the lateral plantar nerves that controls the muscles in the sole of the foot. Next is the deep peroneal nerve. It is the anterior compartment nerve of the leg and the dorsum of the foot. It is one of the terminal branches of the common peroneal nerve. The multiple branches of the superficial peroneal nerve cross along the outer lateral part of the ankle. Now coming to the stability of the joint. Structurally, the ankle joint is very strong. The stability of the joint is ensured by the close interlocking of the articular surfaces, which we have discussed earlier, the strong collateral, the medial and the lateral ligament on the sides, and the tendons that cross the joint, 4 in front and 3 on the posterior medial side and 2 on the posterior lateral side. Coming to the applied anatomy. Ankle sprain, most common, occurs due to the stretching and tearing of the ligament. When the foot is excessively plantar flexed and inverted, the lateral ligament is stretched and torn. Most commonly, the anterior talofibular ligament torns most commonly. And when the plantar flexed foot is excessively everted, the deltoid ligament is not torn, instead it is the avulsion fracture of the medial malleolus. Now the fracture of the malleolar, it is also called the quads fracture, occurs when the foot is everted forcefully. The dislocation of the ankle joint is very uncommon. If it occurs, it is accompanied by the fracture of one malleolar. The picture here shows the injury occurring to the lateral collateral ligament in the plantar flexed and excessively inverted foot. The injury to the deltoid ligament when the foot is everted excessively. Now coming to the subtalar joint. The subtalar joint, it is type, it is the plain synovial joint. Bones forming the subtalar joint are the talus and the calcaneum. The subtalar joint is the two joint complex, the anterior joint and the posterior joint. The anterior joint is formed by the anterior and the medial facet of the calcaneus and their corresponding facet on the talus. You can see the picture here. And the posterior joint consists of the convex shaped facet on the calcaneus and the corresponding concave facet on the talus. There is a complex screw-like movement that occurs during the subtalar joint motion that allows the anterior and the posterior aspect move in opposite direction during the functional movement. The movement that occurs at the subtalar joint are in combination. The picture you can see here. The picture on the right hand side, you can see this on the right side, it is the foot in the neutral position. The picture on the left hand side is the foot in pronation with the main component of eversion and abduction. The range of motion eversion is 10 degrees And the picture in the middle, you can see the foot in supination, the main component of inversion and adduction. The range of motion of inversion is 30 degrees. Therefore, the movement occurring at the subtalar joint are in combination. The stability of the subtalar joint, it is enclosed by the joint capsule, which is lined internally by synovial membrane and strengthened externally by fibrous layer. The capsule is also supported by the three ligaments, the posterior talocalcaneal ligament, medial talocalcaneal ligament, lateral talocalcaneal ligament. The introitious talocalcaneal ligament, which is thick and very strong, and cervical ligament. Now coming to the ligaments at the subtalar joint. First, we have the medial calcaneal ligament. It connects the medial tubercle. Medial calcaneal ligament. It connects the medial tubercle of the back of the talus to the back of the substanticular tali. The lateral calcaneal ligament connects the lateral aspect of the talus to the lateral surface of the calcaneus. The introitious ligament, this you can see here the introitious ligament. It is divided into the posterior and the anterior band. The anterior band is also called the cervical ligament. Collectively, this ligament stabilizes the subtalar joint. The muscles producing the inversion and eversion of the subtalar joint. Inversion muscles are the peroneus longus, brevis, and tertius, and the inversion muscles are the tibialis anterior and the posterior. The nerve supply to the subtalar joint is by the on the plantar aspect by the medial and the lateral plantar nerve. This is the medial and the lateral plantar nerve. It is by the posterior tibial nerve, which divides into the medial and the lateral plantar nerve. Then on the nerve supply on the dorsal aspect is by the deep fibular nerve. The blood supply is by the posterior tibial artery and the fibular artery. Applied, the calcaneal is often fractured in crush-type injury. The most common mechanism of damage is falling onto the heel from a height. The talus is driven into the calcaneus. The bone can break into several pieces known as the comminuted fracture. The subtalar joint is usually disrupted, causing the joint to become arthritic. The patient will experience pain upon inversion and eversion, which can make walking on uneven ground particularly painful. Then coming to the bones of the foot, we have discussed this earlier. Coming to the joints, we have in this, we have the talonavicular joint, the calcaneus cuboid joint. This is also called the metatarsal or the Topper's joint. Then we have the intertarsal joint. Intertarsal joint is the cuneo-navicular joint, the intercuneiform joint, the cuneo-cuboid joint, and the cubonavicular joint. Then we have the tarsal metatarsal joint, the metatarsal phalangeal joint, and the interphalangeal joint. Now coming to the metatarsal joint, it is formed by the talonavicular joint and the calcaneocuboid joint. The talonavicular joint is formed by the head of the talus articulates with the calcaneus, the plantar calcaneonavicular ligament, and the navicular in front. You can see the red line here. This forms the calcaneonavicular ligament, calcaneonavicular joint. Then it allows the gliding and rotation movement, which together with similar movement of the subtalar joint are involved with the inversion and eversion of the foot. Next, we have the calcaneocuboid joint. It is the synovial joint. It is between the facet on the anterior surface of the talus, which is the calcaneocuboid joint, and corresponding facet on the posterior surface of the cuboid. The calcaneocuboid joint allows sliding and rotating movement involved with the eversion and inversion of the foot. Coming to the ligaments of the metatarsal joint, we have the talonavicular ligament, the bifurcate ligament. It is the bifurcate ligament divided into the calcaneonavicular ligament medial and calcaneocuboid ligament lateral. Third is the plantar calcaneonavicular, that is the spring ligament, and the long and the short plantar ligament. Coming to the calcaneonavicular ligament, you can see in this picture, this is the talonavicular ligament. It connects the dorsum, this is the talonavicular ligament, connects the dorsal surface of the neck of the talus to the navicular, stabilizes the talonavicular joint. Then we have the bifurcate ligament. It is divided into the medial and the lateral part. The medial part, it is called the calcaneonavicular ligament. It is a Y-shaped ligament, and the calcaneo connects to the navicular bone. The calcaneocuboid ligament of the bifurcate ligament of the lateral portion. The calcaneus connect with the cuboid on the lateral side. All these ligaments functions to stabilize the metatarsal joint. Then we have the plantar, the calcaneocuboid ligament, and the calcaneonavicular ligament. The plantar calcaneo ligament, the plantar calcaneonavicular, that is the spring ligament, it connects the navicular to the substanticular tendon, functions as the ligamentous sling for the head of the talus and becomes taut during pronation. Then we have the long, this is the long and the short plantar ligament. The long plantar ligament, it is the longest ligament in the sole of the foot and lies inferior to the plantar calcaneocuboid ligament. This is the short plantar ligament. It is short, wide, and very strong. Connects the calcaneum tubercle to the inferior surface of the cuboid. This all ligament stabilizes the metatarsal joint. We have next is the intertarsal joint. This is the cuneo-navicular joint, the intercuneiform joint, the cuneo-cuboid joint, and the cubo-navicular joint. Function of it to transmit the force from the hind foot to the forefoot. There are ligaments that bind the intertarsal joint in the form of Lisfranc complex. It consists of the cuneo-metatarsal joint, the cubo-metatarsal joint, and the intermetatarsal joint. And in this, we have the Lisfranc ligament within the solitary enclosures ligament. It's on the plantar surface of the midfoot between the head of the second metatarsal and the medial cuneiform, and it confirms the stability across the Lisfranc joint. The metatarsal joint it is formed between the metatarsal bones and the adjacent tarsal bones. It is a plain joint. It has limited sliding movement. The range of movement of metatarsal joint between the metatarsals of great toe and the medial cuneiform is greater than that of the other that of the other tarsal metatarsal joints that allows flexion, extension, and rotation. Metatarsophalangeal joint, it is the ellipsoid synovial joint between the head of the metatarsals and the base of the proximal phalanx. It allows the flexion and the extension, limited abduction, adduction, rotation, and circumduction. The deep transverse metatarsal ligament binds the head of the metatarsals together and enables the metatarsal to act as a single unified structure. The blue line shows here the deep transverse ligament. The next is the interphalangeal joint. It is the hinge joint. It is enclosed by the medial and the lateral collateral ligament and by the plantar ligament. In this picture, you can see the plantar ligament in green line. Then we have the deep transverse metatarsal ligament and the collateral ligaments at the interphalangeal joint. Then coming to the muscles of the foot. On the dorsal aspect of the foot, we have the extensor digitorum brevis and extensor hallucis longus. Muscles of the foot. First, we have the dorsal aspect of the foot. We have two muscles, the extensor digitorum brevis and the extensor hallucis longus. This is the extensor digitorum brevis and this is the extensor hallucis longus. The extensor digitorum brevis, it is innervated by the deep fibular nerve of S1 S2. Function, it is the extension of metatarsophalangeal joint of the great toe and extension of the toes second to fourth. Then coming to the muscles of the sole of the foot, they are in the four. The muscles of the sole of the foot are in the four layers. The first layer, muscle of the foot, is formed by the abductor hallucis. This one here, which is shown in the yellow color. We have the flexor digitorum brevis. flexor digitorum brevis, and this is abductor digiti minimis. That's abductor hallucis. It is innervated by the medial plantar nerve from the tibial nerve S1, S2, S3. Function, it abducts and flexes the great toe at the metatarsophalangeal joint. The flexor digitorum brevis. It is innervated by the medial plantar nerve from the tibial nerve S1, S2, S3. Flexes the lateral four toes at the proximal interphalangeal joint. Abductor digiti minimis. Abductor digiti minimis, innervated by the lateral plantar nerve from the tibial nerve S1, S2, S3. Abducts little toe at the metatarsophalangeal joint. Coming to the muscles of the foot, the second layer, we have two, the quadratus plantae and the lumbricals. The quadratus plantae, it is innervated by the lateral plantar nerve from the tibial nerve S1, S2, S3. Functions that assist in the flexor digitorum longus in flexing the toes second to fifth. Then coming to the lumbricals, the first lumbricals medial side of the tendon of the flexor digitorum longus associated with the toe second, the second, third, and the fourth lumbricals. The first lumbricals innervated by the medial plantar nerve from the tibial nerve, and the second, third, and fourth lumbricals innervated by the lateral plantar nerve from the tibial nerve S2, S3. Function of the lumbricals, flexion of metatarsophalangeal joint and extension of interphalangeal joint. Coming to the third layer of the muscles of the sole of the foot, we have three muscles here: the flexor hallucis brevis, the adductor hallucis, and the flexor digiti minimi brevis. The flexor hallucis brevis, it is innervated by the medial plantar nerve from the tibial nerve S1, S2. Function of the flexor hallucis brevis, it flexes the metatarsophalangeal joint of the great toe. Adductor hallucis, it is innervated by the lateral plantar nerve from the tibial nerve S2, S3. Adducts the great toe at the metatarsophalangeal joint. The flexor digiti minimi brevis, innervation by the lateral plantar nerve from the tibial nerve S2, S3. Function, flexes little toe at the metatarsophalangeal joint. Muscles, the four layer muscles of the sole of the foot, it is formed by the dorsal interossei and the plantar interossei. The dorsal interossei, innervation by the lateral plantar nerve from the tibial nerve. Function of the dorsal interossei, abduction of the toes second to the fourth at the metatarsophalangeal joint. The plantar interossei, innervation by the lateral plantar nerve from the tibial nerve S2, S3. Function of the plantar interossei is the adduction of the toes, fourth, adduction of the toes third to fifth at the metatarsophalangeal joint. Coming to the nerve supply and blood supply. As discussed in the ankle joint, We have discussed this, the nerve supply and the blood supply in the ankle joint. Now coming to the arches of the foot. It is divided into the two longitudinal arch, that is medial and the lateral longitudinal arch, and the two transverse arch, the anterior and the posterior transverse arch. This is the medial longitudinal arch, this is the lateral longitudinal arch, and these are the two transverse arches, the anterior and the posterior. Now coming to the medial longitudinal arch. It's on, ma'am. Hello.
हाँ अभी record हो रहा है. You can start now.
I'll start from the arches. Hello.
Yeah, from the medial one. You just repeated the 2 line before that. You can repeat. That's it.
Coming to the medial longitudinal arch. This is higher as compared to the lateral longitudinal arch. It has it is more mobile, and it is formed by more bones and more joints. The medial longitudinal arch is formed by the calcaneus, the talus, the navicular, and the 3 cuneiform bones, and the 3 metatarsals. The function of the medial longitudinal arch is the mobility, the lateral longitudinal arch. It is relatively lower and stronger. Its main function is weight bearing. It is formed by the cuboid, the metatarsals, and the calcaneum. Coming to the functions of the arches, it helps in weight bearing and in providing upright posture. The foot acts as a pliable platform to support and divide the body weight about equally. It acts as a lever to propel the body in walking or running or in jumping. It acts as a shock absorber, adapts to the changes when walking on uneven surfaces, and it also provides protection, helps to protect the soft tissues of the sole whenever the foot is pressing against the floor. Now coming to the common foot injuries, we have the neuromas, the stress fracture of the foot, plantar fasciitis, heel spur, knee unions, rheumatoiditis, Achilles tendinitis, ankle sprain, fracture of the ankle, retrocalcaneal bursitis, metatarsalgia, and arthritis. These are the common injuries which occur at the ankle and the foot. Here I complete my ankle anatomy of ankle and foot. Thank you.
Hello.
Ma'am, I've finished.
Okay. All the participants, they can get these ankle videos in a GAPT YouTube channel. So kindly you can subscribe. Those who have missed because of their poor connection, they can refer from there. And all the participant e-certificate will be available soon within 4 to 5 working days. So kindly cooperate for that time. Thank you, everyone. We'll see you with the next upcoming webinar. Thank you so much. Ma'am, we can close the webinar.
Okay, thank you so much.